The following is our technique for open gluteus medius double row repair with acellular allograft augmentation. Here are our disclosures. Gluteus medius tears are more common in older patients, particularly females, and are most typically degenerative in nature. While traumatic etiologies are possible and may occur in younger patients, these are rare. Degenerative medius tears typically originate from the central fibers of the insertion, then propagate anteriorly and posteriorly. The gluteus medius origin starts at the anterosuperior iliac spine, then spans the entirety of the iliac crest, ending at the posterior superior iliac spine. There are three components to the medius tendon. The anterior and middle fibers insert onto the lateral facet, while the posterior fibers insert onto the superior-posterior facet. The gluteus minimus originates on the iliac wing from the anterior inferior iliac spine to the posterior inferior iliac spine along the middle gluteal line. It inserts onto the anterior facet of the greater trochanter. Given the morbidity associated with abductor insufficiency or deficiency, it is not surprising that a multitude of repair techniques exist. Each has various indications and are optimal in different clinical situations. Both open and endoscopic techniques have been evaluated in biomechanical studies, with most finding similar load to failure between methods. Importantly, the most common mode of failure in biomechanical studies is often the muscle pulling off its origin, not the repair construct itself, suggesting repairs using either technique can be robust. A 2012 cadaver study comparing knotted versus knotless double-row gluteus medius repairs found the knotless technique to be equal or superior to the knotted technique for both cyclic loading and load-to-failure trials. With that background in mind, we present a case of a 69-year-old female that presented with 1 year of right lateral and buttock pain, which acutely worsened over the 2.5 months prior to presentation. Bursal injections initially provided relief, but their efficacy waned and her pain limits her ability to perform activities of daily living. On physical exam, the patient had a slight Trendelenburg gait with weak hip abduction and tenderness over the greater trochanter. AP and done lateral x-rays of the right hip demonstrate tonus grade 0 and no bony abnormalities. MRI of the left hip without contrast demonstrates a full thickness gluteus medius tear with about 2.5 centimeters of retraction. This can best be appreciated on the coronal and sagittal images. The primary benefit of acellular allografts is they may provide additional time-zero strength to a repair. Accordingly, indications for allograft use are related to tendon quality, where there is concern for ability to achieve a robust repair in the OR. The following is our surgical technique. The patient is placed in a lateral decubitus position with the operative limb free. Landmarks for the lateral approach to the hip include the greater trochanter and the proximal femoral shaft. An incision is made directly over the greater troch, between 4 and 6 centimeters in length, with 2/3 proximal and 1/3 distal to the center of the troch. After subcutaneous dissection, the fascia is divided, centered over the greater troch, with care not to injure the underlying abductor tendons. The trochanteric bursa is then excised. Abductor tear identification can be challenging, and care must be taken not to iatrogenically injure the tendon while trying to expose it. The superficial layer attracted with the cob may be excised, but the senior author prefers to incorporate it into the repair, as it can have a muscular component. The tendon is found deep to this layer and provisionally reduced to its footprint. A traction suture is placed through the tendon to aid with mobilization and tendon reduction. This is placed in a figure-of-8 fashion to prevent suture pull-through. A second traction suture through the medius is placed to provide a stronger, more uniformly distributed force vector. Finally, a third traction suture is placed anteriorly through the gluteus minimus, which was also torn in this case. The gluteus medius has two insertions. First, the superior-posterior facet can be seen here, and then the lateral facet insertion. The footprint is decorticated with a burr to augment the tendon-to-bone healing response. Changing limb position may help with footprint exposure. External rotation can help improve visualization of the anterior troch, while internal rotation helps with posterior visualization. The first anchor is placed at the superior-posterior aspect of the footprint, and the second anchor is placed anterior to this one. Each are triple loaded. The graft will sit on top of the tendon and is incorporated into the repair construct. The graft should be rectangular in shape and should be large enough to span the tendon proximal to the proximal row and distal to the distal row. A ruler is used to ensure appropriate length and width are obtained. These measurements are drawn on the graft itself, and it is cut to the desired specifications. The graft is provisionally fixed to the tendon with vicryl sutures anteriorly and posteriorly to ensure correct placement in the desired location. Sutures from the superior posterior anchor are passed through the tendon, then through the allograft in mattress fashion. This is done a total of 6 times, which will allow for 3 mattress knots. Next, 4 suture limbs from the superior anterior anchor are placed through the tendon and allograft, which will allow for 2 mattress knots. With 10 limbs through the medius to form the proximal row, attention is turned towards the minimus. The remaining 2 suture limbs from the anterior superior anchor are passed through the minimus. The leg is internally rotated to allow access to the posterior trochanter. Mattress knots are tied sequentially from posterior to anterior. Each suture limb here is through both the medius tendon and the dermal allograft. With the proximal row secured, attention is turned towards the distal row. The distal row will consist of 2 knotless anchors, one anterior and one posterior. Each anchor will receive 5 suture limbs, one from each mattress knot securing the medius tendon from the proximal row. The suture limbs previously passed through the minimus are now passed through the allograft. In this case, this was done after securing the distal row so that the final graft position would be known and this mattress suture would assist in securing the edge. The hip is taken through a range of motion to confirm adequacy of repair. The muscle tendon bone complex can be seen moving as a unit throughout range of motion with the graft secured in place. To summarize the surgical sequence, a direct lateral approach is used, centered over the greater trochanter. Next, the glute medius and minimus tendons are identified, then mobilized to increase excursion and then provisionally reduced to the footprint. The tendon footprint is debrided and proximal row anchors are placed. Sutures are then passed from the proximal row through the tendon and prepared allograft. 1 suture limb from each mattress is placed into a double row anchor into the distal row, and finally the repair is then checked. Postoperatively, patients are kept partial weight bearing for 2 weeks with a hip brace preventing extremes of motion. Starting at 6 weeks, patients progress to full weight bearing and then transition out of the brace. At 12 weeks, patients should be ambulating without assistance. Outcome studies are currently limited, but a 2021 study of 8 patients that underwent abductor reconstruction with a dermal allograft found no re-tears at 1-year follow-up, with 75% of patients above pass based on the modified Harris hip score. Another recent study using the mini-open double row technique found patients had significantly improved abductor strength, decreased Trendelenburg sign, and improved modified Harris hip scores, providing clinical evidence of technique efficacy. Thank you for your attention.